Good morning, my dear students. Our next topic is dacryocystitis. So, dacryocystitis, from the name itself, dacryocystitis is a Greek term. Okay, so dacryo means tear, cysta means sac, and itis means, you all know, it is an inflammation. So, dacryocystitis is the inflammation of lacrimal sac. So, dacryocystitis is inflammation of lacrimal sac. It's a common condition, and it may occur in two forms. In this picture, you can see, right, this is the lacrimal sac region, and you can see a reddish swollen region. This is the inflammation of lacrimal sac. So it can occur in two forms: congenital and adult. Adult can again divide it into acute and chronic form. So we are mainly dealing with three things: congenital dacryocystitis, chronic dacryocystitis, and acute dacryocystitis. So first one is congenital dacryocystitis. So congenital dacryocystitis. So it's the inflammation of lacrimal sac occurring in newborn infants. During the birth, they will have dacryocystitis. So it is also known as dacryocystitis neonatorum. So this lacrimal sac, inflammation of lacrimal sac, is known as congenital dacryocystitis. Another name for congenital dacryocystitis is dacryocystitis neonatorum. So etiology: causes for congenital dacryocystitis are: all dacryocystitis are formed due to a stasis of secretion in the lacrimal sac. Okay, there will be a stasis or a collection of secretion in the lacrimal sac. Here it is due to the congenital blockage in the nasolacrimal duct. So in congenital dacryocystitis, the status of secretion is due to the congenital blockage in the nasolacrimal duct. So it's very common in occurrence, and in this congenital dacryocystitis, there are a lot of reason for the blockage, congenital blockage of nasolacrimal duct. In that, 30% is due to the membranous occlusion in the lower end near the valve of Hasner. That is the main cause for the congenital dacryocystitis. So there will be membranous occlusion in the lower end, that is near the valve of Hasner. That will cause the closure of nasolacrimal duct, and there will be stasis of secretion, and it will lead to congenital dacryocystitis. So other reasons for congenital dacryocystitis are: presence of epithelial debris. Epithelial debris seen in the nasolacrimal duct can block the nasolacrimal duct and can lead to congenital nasolacrimal duct block. Or membranous occlusion at its upper end. Before we discuss about the membranous occlusion in the lower end. Here we are mentioning the membranous occlusion at its upper end near the lacrimal sac. Complete non-canalization. There is no canal formation. Rarely bony occlusion. Sometimes there will be bony occlusion also. So next comes the common bacteria associated with congenital dacryocystitis: Staphylococci, Pneumococci, and Streptococci. These are the common bacteria causing congenital dacryocystitis. So nasolacrimal duct block during birth is the main reason for stasis of lacrimal secretion in the lacrimal sac, which leads to the congenital dacryocystitis. So clinical features, the symptoms: congenital dacryocystitis usually presents with a mild grade chronic inflammation. Okay, it is characterized by epiphora. Epiphora, it develops after 7 days of birth. After 7 days of birth, there will be watering eyes, and it is followed by copious mucopurulent discharge from the eyes. There will be mucopurulent discharge followed by epiphora. Regurgitation test is usually positive. If we do regurgitation test, if we give pressure over the lacrimal sac area, purulent discharge regurgitates from the lower puncta. Swelling on the sac area may appear eventually. So there will be mild grade chronic inflammation. Epiphora will be there. There will be watering of eyes followed by mucopurulent discharge. If we do regurgitation test, purulent discharge will come out from the lower puncta, and the swelling of the sac may appear eventually. These are the symptoms of or clinical picture of congenital dacryocystitis. Differential diagnosis. The differential diagnosis is mainly to ophthalmia neonatorum and congenital glaucoma. Complications. Complications, if we are not treating on time, it will lead to recurrent conjunctivitis, acute or chronic dacryocystitis itself, lacrimal abscess formation and fistula formation. Treatment. Treatment mainly depends upon the age at which the child is brought to us. So first one is massage over the lacrimal sac area and topical antibiotics. So if the baby is brought to them around 6 to 8 weeks of age, then we can do this massage over lacrimal sac area. So massage, how it works? The massage increases the hydrostatic pressure. Hydrostatic pressure is increased in the sac, which helps to open up the membranous occlusion. So it should be carried out at least 4 times a day, and after that we have to instill antibiotic drops. So we have to give a massage over the lacrimal sac area. We have to give a downward drop, and due to this there will be an increase in hydrostatic pressure, and that helps to open the membranous occlusion. And we have to do at least 4 times a day, and after that we have to instill the antibiotic drops. This treatment cures obstruction in about 90% of the infants. So this we have to do in 6 to 8 weeks of age infants. So we have to give a downward stroke. So first treatment is massage of the lacrimal sac and then antibiotic drops instillation. Next is lacrimal syringing. Already we discussed this in watering eyes. So lacrimal syringing or irrigation with normal saline and antibiotic solution. So this one we have to do up to the age of 2 months. So the condition is not cured up to the age of 2 months. So at that time we can go for lacrimal syringing. So lacrimal syringing helps to open the membranous occlusion by exerting hydraulic pressure. The syringing may be carried out once or twice a week. So in a week, once or twice we have to do the lacrimal syringing, and it will exert a hydraulic pressure in this area. The third one is probing. So first one is massaging, second one is lacrimal syringing, and third one is probing. That can be, if it is not cured by the age of 3 to 4 months or up to 6 months, we can go for probing. So we will do a probing in the nasolacrimal duct. It's usually performed under general anesthesia. While performed probing, care must be given not to injure the canaliculus. So very carefully we have to do not to injure the canaliculus. In most instances, a single probing will relieve the obstruction. In case of failure, we have to repeat with an interval of 3 to 4 times. So normally with single probing, we will get the result. If there is a failure, then we have to repeat this probing after 3 to 4 weeks. That is probing. You can see prob. So these are different types of different sizes. Prob, lacrimal prob with the different sizes. This is punctum dilator. Using this, we can dilate the punctum. After probing, next comes intubations. Intubations with silicone tube. It is performed if repeated probing also fail, then we have to do intubation. Silicone tube should be kept into the nasolacrimal duct for about 6 months. So we have to keep that silicone tube inside the nasolacrimal duct for 6 months. This is intubation with silicone tube. This is silicone tube. This is how it looks like. So next comes the dacryocystomy operation. So if all these things failed, then we have to go for surgery. When the child is brought very late or repeated probing is a failure, then conservative treatment by massaging, topical antibiotics and intermittent syringing should be continued till the age of 4. After this, we can go for DCR operation. DCR is dacryocystomy operation. So all this treatment failed, then we have to wait till 4 years. In between, we can give the conservative treatments like massage, syringing, topical antibiotics and all. But after 4 years, this will recur if if the treatment is not proper, so after 4 years we can ask them to do surgery. This dacrocystorhinotomy surgery. Surgery in detail we'll discuss in the final slides. So that is about the congenital dacryocystitis. So the treatment for our first one massage, next syringing, propping, and then intubation, and if all just fails, we can go for the surgery, DCR surgery. Hope you understood congenital dacryocystitis. Next comes the adult dacryocystitis. In that, first one is chronic dacryocystitis. It's very common than the acute dacryocystitis. So etiology multifactorial. Here also the main cause for dacryocystitis is the stasis, and there is mild infection for long duration. These both will lead to chronic dacryocystitis. Here the etiological factors can be grouped under predisposing factors, factors responsible for stasis, and source of infection and causative organism. So first one is predisposing factors. So predisposing factors, first one is age. It is more common among 40 to 60 years of age. Sex, most predominantly seen in females. Race, rarer among Negroes than whites. Hereditary, it plays an indirect role because it affects the facial configuration, so length and width of the bony canal. So hereditary plays an indirect role. Socioeconomic status, it's common in low socioeconomic status, and poor personal hygiene. It's an important thing, poor personal hygiene. This is predisposing factors. Next comes the factors responsible for stasis of tears in lacrimal sac. So in that, first one is anatomical cause. There will be comparatively narrow bony canal or partial canalization. Canal formation is not proper. Of membranous nasolacrimal duct and excessive membranous fold in the nasolacrimal duct. There is more nasal or excessive membranous fold are present in nasolacrimal duct. These are the anatomical causes. Next comes foreign bodies. Foreign bodies may block the nasolacrimal duct, and there will be stasis of tears. Next comes the excessive lacrimation. That may be due to primary or reflex lacrimation. Causes for primary and reflex lacrimation already we discussed in watering eyes. Mild grade inflammation of lacrimal sac due to associated recurrent conjunctivitis. Due to the recurrent conjunctivitis, there will be block in the nasolacrimal duct by epithelial debris and mucus plug. These all will cause stasis of tears. And one more thing is obstruction of lower end of nasolacrimal duct by nasal diseases. Due to the diseases of the nose, there will be obstruction in the lower end of the nasolacrimal duct. The diseases are polyps, hypertrophy inferior concave, marked degree of deviated nasal septum, tumors, and atrophic rhinitis, and these causes stenosis, and that will lead to the stagnation of tears in the lacrimal sac. So these are the diseases affecting the nose which will lead to the stasis of tears in the lacrimal sac. Next comes the source of infection. Lacrimal sac may get infected from the surrounding structures, from the conjunctiva, nasal cavity, or paranasal sinuses. Causative organism, Staphylococcus, Pneumococci, Streptococci, Pseudomonas. All this can cause dacryocystitis. Rarely, chronic granulomatous infections like tuberculosis, syphilis, leprosy, and occasionally rhinosporiodosis may also cause dacryocystitis. These are the causative organisms and associated diseases which may lead to dacryocystitis. So this is the etiology for chronic dacryocystitis. So chronic dacryocystitis is mainly due to the stasis of tear and long-standing mild infection. Next comes the clinical picture of chronic dacryocystitis that can be divided into 4 stages. So first stage is chronic catarrhal dacryocystitis. Here there will be mild inflammation of the lacrimal sac associated with block of nasolacrimal duct. So there is a mild infection or inflammation. In this stage, the only symptom is watering eye. Sometimes mild redness can be seen in the inner canthus. And if you do lacrimal syringing, clear fluid may come out, or a few fibrous mucoid flakes regurgitate from the puncta. If you do dacrocystography, that reveals a block in the nasolacrimal duct, but the lacrimal sac looks normal with a normal mucosa. So this we can see in chronic catarrhal dacryocystitis stage. So the first stage, there will be only mild inflammation of the lacrimal sac, and the only symptom is watering, and there will be mild redness over the lacrimal sac area. If you do syringing, mostly clear fluids will come. Sometimes mucoid flakes will regurgitate, and dacrocystography shows a block in the nasolacrimal duct. This is the first stage. Next comes the second stage. That is lacrimal stage of lacrimal mucocele. Forms a mucocele. So there is a distension of lacrimal sac, characterized by constant epiphora. This constant epiphora associated with swelling just below the inner canthus. Milky or gelatinous mucoid fluid regurgitate. If you do pressing of the swelling, or if you do lacrimal syringing, milky or gelatinous mucoid fluid regurgitates. Dacrocystography at this stage reveals distended sac. This sac is distended with blockage somewhere in the nasolacrimal duct. Sometimes, due to continued chronic infection, the canaliculae, both the opening of both the canaliculae into the sac are blocked, and a large fluctuating swelling is seen at the inner canthus with a negative regurgitation test. This is called encysted mucocele. So, if the infection continued, the chronic infection continued, both the canaliculae sac will get closed. So, if we do regurgitation test, we will get a negative regurgitation test due to blocked canaliculae. So, the canaliculae is blocked, so the collection of mucus cannot come out through the canaliculae into the puncta. So, it will form a cyst. So, that is encysted mucocele. So, this stage is known as lacrimal mucocele. So, here the distension of the sac occurs. There will be epiphora and swelling just below the inner canthus. If we do regurgitation test, milky or gelatinous mucoid will come out. Dacryocystitis shows distended sac, and we can see encysted mucocele in this condition. Next is, here you can see, this is encysted mucocele. Next is stage of chronic suppurative dacryocystitis. So here suppuration, that is pyogenic organism, started infecting. So due to pyogenic infection, the mucoid discharge becomes purulent, converting the mucocele into a pyocele. There the mucocele is converted into a pyocele. The condition is characterized by epiphora, associated recurrent conjunctivitis, swelling at inner canthus with mild erythema of underlying skin. On regurgitation, a frank purulent discharge flows from the lower puncta. If openings of canaliculae are blocked, at this stage the so-called encysted pyocele occurs. So here the pyogenic infection occurs, and epiphora, watering is there, recurrent conjunctivitis will be there, swelling can be seen with mild erythema of the mild redness over the skin, overlying skin. So, if we do regurgitation test, purulent discharge, first discharge will come out from the lower puncta, and if the canaliculae are blocked, we can see encysted pyocele also. Next comes the fourth stage, that is fibrosis, stage of chronic fibrotic sac. Here, the fibrosis of this sac occur. So, low-grade repeated infection for a prolonged period ultimately result in small fibrotic sac due to thickening of the mucosa. Thickening of the mucosa occurs, and this chronic fibrotic sac results. This is associated with persistent epiphora and discharge. So, this is stage of chronic fibrotic sac. These are the four stages of chronic dacryocystitis. So, first one is chronic catarrhal, second one is mucocele, third one pyocele, and the fourth one is chronic fibrotic sac. So, these are the four stages. Complications: chronic conjunctivitis, acute or chronic dacryocystitis, ectropion of lower lid. That is, ectropion means outward intern of lower lid, maceration and eczema of lower lid skin due to prolonged watering, simple corneal abrasions that may get infected and will change into corneal ulcer, hypopyon ulcer. And the main complication is, in the presence of dacryocystitis, if an intraocular surgery is performed, there is a high risk of developing endophthalmitis. Endophthalmitis is the infection of full eye. So from the lacrimal sac, the infection can spread to the whole eye. So if an intraocular surgery is performing, before that we have to do syringing of lacrimal sac and washed all the contents inside that before doing a surgery. So these are the complications of chronic dacryocystitis. Next comes the treatment. First is conservative treatment by repeated lacrimal syringing. It is useful only in the recent cases. In long-standing cases, syringing and even probing does not have any result. So in recent cases only we have to go for repeated lacrimal syringing. Otherwise, we have to go for surgeries. Dacryocystomy. So it is operation of choice to re-establish the lacrimal drainage. However, before performing surgery, the infection, especially piocele, should be controlled by topical antibiotics and repeated syringing. So before performing the surgery, we have to control the infection and by topical antibiotics and repeated syringing can be done. In detail, we will discuss about the surgery, the last slides. Dacryocystectomy. Cystectomy is removing of the lacrimal sac. So it should be performed only when dacryocystomy is contraindicated. So indications of dacryocystectomy are too young, less than 4 years age or more than 60 years of age, we can go for this surgery. Markedly shrunken and fibrosed sac. The sac is already fibrous, then no need of reconstructing it, right? So we can remove that one. Tuberculosis, syphilis, leprosy or mycotic infection of the sac. Tumors of the sac. Gross nasal diseases like atopic rhinitis. And an unskilled surgeon, because it is said that a good DCT, that is dacryocystectomy, is always better than a badly done dacryocystomy. So these are the indications of dacryocystectomy, removal of lacrimal sac. This surgery also we will discuss. Last, congenital dacryocystomy. It is performed in presence of blocked canaliculae. If blocked canaliculae is also there, then we have to do this one, congenital dacryocystomy. So that is about chronic dacryocystitis. Next comes the acute dacryocystitis. So from the name itself, we know this is an acute condition. So acute dacryocystitis is an acute suppurative inflammation of lacrimal sac characterized by presence of painful swelling in the region of sac. There will be painful swelling in the region of lacrimal sac. This is acute dacryocystitis. The causes for acute dacryocystitis can be divided into two. It may develop in two ways. Okay, first one is acute exacerbation of chronic dacryocystitis. There is already chronic dacryocystitis, and acute exacerbation may lead to acute dacryocystitis, or as an acute peridacryocystitis. Peridacryocystitis means around the lacrimal sac, what all structures are there, the infection can spread from that structures to the lacrimal sac. So, as an acute peridacryocystitis due to direct involvement from the neighboring infected structures such as paranasal sinus, surrounding bones or dental caries or abscess of teeth in the upper jaw. From that also it can spread to the lacrimal sac. So, that is acute peridacryocystitis. And causative organisms for acute dacryocystitis are commonly involved are Streptococcus, Pneumococcus, and Staphylococcus. Clinical features. Clinical features of acute dacryocystitis can be divided into 3 stages. In chronic dacryocystitis, we mentioned about 4 stages. Here we are mentioning about here it is divided into 3 stages. First one is stage of cellulitis. So it is characterized by a painful swelling in the region of lacrimal sac associated with epiphora, and general symptoms like fever and malaise can also be seen. So first one is cellulitis. So in cellulitis, there will be a painful swelling in the region of lacrimal sac. The swelling is red, hot, firm, and tender. Redness and edema also spread to lids and cheeks. We can see redness in lids and cheeks also. When treated, resolution may occur at this stage. If untreated, self-resolution is rare. So in this stage, if we treat, it will subside. Otherwise, self-resolution is rare in this condition. If we are not treating, it will go to the next stage. So first is stage of cellulitis. Second is stage of abscess formation. So lacrimal abscess is formed. Continued inflammation causes occlusion of the canaliculae due to edema. So there the occlusion of canaliculae occur. The sac is filled with pus, then sac is distended and anterior wall ruptures, forming a pericystic swelling. In this way, a large fluctuating swelling, the lacrimal abscess, is formed. So if the inflammation continues, there will be occlusion of lacrimal canaliculae due to edema, which makes the sac filled with pus, and it will get distended and the anterior wall ruptures and the lacrimal abscess forms. It usually points below to the outside of the sac owing to the gravitation of pus and presence of the medial palpebral ligament in the upper part. So this is stage of lacrimal abscess. So first is stage of cellulitis, next is stage of lacrimal abscess, and next is fistula formation. So the so formed pus has to come out from the abscess. So it can come externally or it can go internally through some path, that is fistula. So when the lacrimal abscess is left unattended, it discharges spontaneously, leaving an external fistula. This is external fistula below the medial palpebral ligament. This is a common thing, and rarely the abscess may open into the nasal cavity, forming an internal fistula. So stage of fistula formation here, due to the abscess, there is lot of pus collection inside the sac. It has to go out or go in. So if it is coming out through a part with an external opening, then it is known as external fistula. It will be seen mainly below the medial palpebral ligament. Okay, this is, if it is going internally, it will go and open inside the nasal cavity, forming an internal fistula. So these are the 3 stages of acute dacryocystitis: cellulitis, second one is abscess formation, and third one is fistula formation. Next comes the complications: acute conjunctivitis, corneal abrasions, converting corneal ulcers, lid abscess, osteomyelitis of lacrimal bone, orbital cellulitis, facial cellulitis, ethmoiditis, or rarely cavernous sinus thrombosis, and very rarely generalized septicemia may also develop. All these are the complications of acute dacryocystitis. Next comes the treatment. So during cellulitis stage, we can give systemic and topical antibiotics to control the infection. Also, they used to give anti-inflammatory analgesic drugs and a hot fomentation to relieve pain and swelling. This is the initial treatment, initial level treatment. If it is in the second stage, that is in the abscess formation, in addition to the above treatment, that is we have to give systemic and topical antibiotics and analgesic drugs, and after that, when pus starts pointing on the skin, it should be drained with a small incision. We have to put a small incision and drain the pus out. The pus should be gently squeezed out. Dressing done with betadine soft roll gauze. We have to first remove, do an incision and take out the content, and then dressing. They used to give dressing with betadine soft gauze. And later on, depending upon the condition of the lacrimal sac, either DCT or DCR, dacrocystectomy or dacrocystorhinotomy operation should be carried out. Otherwise, recurrence will be there. That is in the second stage. Next comes the third stage, that is external lacrimal fistula is formed. There, the treatment should be, after controlling the acute infection with systemic antibiotics, fistulectomy along with dacrocystectomy or dacrocystorhinotomy operation should be performed. So here fistulectomy should be done first. After that DCT or DCR operation should be performed. So now we will discuss about acute dacryocystitis. So congenital dacryocystitis over, chronic dacryocystitis over and acute dacryocystitis over. Now we will discuss about the surgical techniques mentioned for dacryocystitis. In that, first one is dacrocystorhinotomy. DCR, it is commonly known as DCR. It can be done in two techniques. One is conventional external approach or endonasal DCR. So external is through the external skin we can approach to lacrimal sac, or endonasal means from inside the nose we can reach the lacrimal sac. So this is, we will go detail. So first one is conventional external approach DCR. So here first step is anesthesia. So general anesthesia is preferred, but sometimes they will do with local infiltration anesthesia in adults. First we have to give anesthesia, then skin incision, either a curved incision along the anterior lacrimal crest or a straight incision 8 mm medial to the medial canthus is made. So skin incision, curved incision along the anterior lacrimal crest or a straight incision 8 mm medial to the medial canthus can be done. After doing that incision, exposure of medial palpebral ligament and anterior lacrimal crest. Okay, first we did an incision. After that, we are exposing medial palpebral ligament and anterior lacrimal crest. So medial palpebral ligament is exposed by blunt dissection and cut with scissors to expose the anterior lacrimal crest. So once we did skin incision, then we can see medial palpebral ligament. We have to cut that to expose the anterior lacrimal crest. Dissection of lacrimal sac. After that, periosteum is separated from the anterior lacrimal crest. We cut open the medial palpebral ligament, then we saw the anterior crest, then periosteum is separated along with the lacrimal sac is reflected laterally. The lacrimal sac is reflected laterally with the blunt dissection exposing the lacrimal fossa. Then we can see the lacrimal fossa. Exposure of nasal mucosa. So here we have to do 15 mm into 10 mm bony ostium is made by removing the anterior lacrimal crest and the bones forming lacrimal fossa. So here we have to do a cut in the bony ostium. First we have to remove the anterior lacrimal crest and the bones forming the lacrimal fossa. This we have to remove, and thus exposing the thick pinkish white mucosa and expose the nasal mucosa. Preparation of flaps of sac. Then we have to make flaps of sacs. We have to cut the sac, lacrimal sac. A probe, before that we have to do probing. A probe is introduced in the sac through lower canaliculae and the sac is incised vertically. So first we have to insert a probe through the lower canaliculae into the sac to visualize the sac properly, to understand the sac properly. After that we have to do a vertical cut in the sac. To prepare anterior and posterior flaps, this incision is converted into a H-shaped. So we have to cut it into a H-shape to make the anterior and posterior flap. So we have to cut the lacrimal sac into an anterior flap and a posterior flap. Fashioning of nasal mucosal flap. Nasal mucosa also we have to do a vertical incision and convert it into a H-shaped anterior and posterior flap. So now we got anterior and posterior flap in nasal mucosa and anterior and posterior flap in lacrimal sac also. So suturing of flaps. So now what we have to do is we have to suture. The posterior flap of nasal mucosa is sutured with posterior flap of the sac, and anterior flap of the nasal mucosa is sutured with anterior flap of the sac. So there is no nasal sac, right? It is open now, open directly into the nasal mucosa. So it is followed by suturing of anterior flaps. So the anterior flap of the lacrimal sac is sutured with anterior flap of the nasal mucosa, and posterior flap of the lacrimal sac is sutured with posterior flap of the nasal mucosa. So now it is open. No need of connection with the nasolacrimal duct, that is directly open into the lacrimal sac, is directly open into the nasal mucosa. Next, closure. We have to suture back the medial palpebral ligament into the periosteum. Orbicularis muscles is sutured and skin is sutured back. So this is the external approach DCR, dacryocystocytomy. This is the link. This I will give in my comment box, so you can go and watch the surgery video. Endonasal DCR. So presently many eye surgeons along with the ENT surgeons preferring endonasal DCR over external approach because of its advantage that I mentioned in coming slides. So surgical steps of endonasal DCRs are: first one, preparation and anesthesia. So here we have to prepare the nasal mucosa before 15 to 30 minutes of surgery. Okay, so we have to put nasal decongestant drops and local anesthetic agents in the nose. Then conjunctival sac is also anesthetized by topical instillation of 2% lignocaine, and also the surrounding area can also be anesthetized by injecting lignocaine 2% with adrenaline in the medial parts of upper and lower eyelids, and via subcarangular injection to the lacrimal fossa region. So this way we have to prepare and give anesthesia. After that, we have to, after giving anesthesia, we have to identify the sac area. For that, we use 20 gauge light pipe is inserted via the upper canaliculi in the sac. So a light is inserted via the upper canaliculi into the sac. So you have to keep in mind then how much small the light should be. It has to pass through the small canaliculi into the sac. With the help of endoscope that is inserted via the nose, the sac area which is transilluminated by the light pipe is identified, and a further injection of lignocaine with adrenaline is made below the nasal mucosa in this area. So first we are illuminating the sac by inserting a light pipe via the upper canaliculi into the sac, and through the endoscope with a camera inserted via the nose, we can see the sac which is illuminated with the light we already introduced through the upper canaliculi. We can give injection anesthesia in this region in the nasal mucosa area. Next step is creation of opening in the nasal mucosa, and then bones forming the lacrimal fossa and the posteromedial wall of the sac can be accomplished by two techniques. So next step is, now we are identified the sac, we gave anesthesia there. Next step is we have to first remove the nasal mucosa. We are going via the nose, right? So from inside to outside we are going. So first we have to cut open the nasal mucosa, then we have to open the bones forming the lacrimal fossa, then posterior wall of the lacrimal sac we have to open. So this can be done with two techniques: one by cutting the tissues with appropriate instruments, or by ablation, laser ablation also we can open these structures. After opening all these structures, stenting of rhinotomy opening. This opening we have to do stenting. So for that, the outflow system is then stented using fine silicone tubes. Using silicone tubes, we have to stent tubes. We'll keep the stent inside. tubes passed via the superior and inferior canaliculae into the rhinotomy, where we cut open the portions and secured with a process of knotting. We will put a knot and secure it. Nasal packing and dressing is done. So after opening this nasal mucosa, bone and lacrimal sac, we will pass a silicon tube, that is a stent. We will keep a stent inside there. So this is inserted through superior and inferior canaliculae, and a knot is done inside the nose and keep. So after that, nasal packing is done and dressing is done. So post-operative care and removal of stent. After 24 hours of operation, nasal packs are removed and patient is advised to use decongestant, antibiotic and steroid nasal drops for 3 to 4 weeks. And the lacrimal stents are removed after 8 to 12 weeks after surgery. And the nasal drops should be continued further for 2 to 3 weeks. So this stent is removed after 8 to 12 weeks only, and decongestant, antibiotic drops, steroid nasal drops and all will give to the patient. This is endonasal DCR. You can go through this YouTube link to see this endonasal DCR also. This is advantages and disadvantages of endoscopic and external DCR. So here this is endoscopic DCR and external DCR. Advantages of endoscopic DCRs are no external scar is present, but here cutaneous scar can be seen in external DCR. Relatively bloodless surgery, relatively more bleeding during surgery, better visualization of nasal pathology, here it is not there. Less chances of injury to ethmoidal vessels and cribriform plate. Here that is an endoscope because we are going via nasal pad. Potential injury to the adjacent medial canthus structures. There is a chance of getting injury. Less time consuming, 15 to 30 minutes only, because since nasal mucosal flap and sac wall flaps are not made. So here more operation time because we have to make the flaps and then suturing back the lacrimal sac flaps to the nasal mucosa flap. It will take time, so it will take 1 hour. No post-operative morbidity. Here post-operative morbidities are more. Then endoscopic disadvantages and external DCR advantages. Here in endoscopic DCR, the less success rate, but in external method there is more success rate. Requires skilled ophthalmologist and rhinologist. Both are ENT surgeon and ophthalmologist are required. Here in external approach only ophthalmologist can done. Expensive equipments like endoscope, camera, light, that canaliculae which we insert, all those things are expensive. Here not expensive equipments required. Requires a reasonable access to middle meatus and familiarity with endoscopic anatomy should be there in endoscopic surgery. Does not require any familiarity with endoscopic structures. So these are the advantages and disadvantages of external and endoscopic DCR. Next comes the DCT, Dacryocystitis, that is removal of the lacrimal sac. Here 1 to 4 steps are same as for external DCR operation, that is anesthesia, skin incision, then cutting of medial palpebral ligament and exposing the anterior crust of lacrimal bone and also reflecting the lacrimal sac. Till that it is same. After reflecting with the lacrimal sac with blunt dissection, we have to do. After exposing the sac, it is separated from the surrounding structures by blunt dissection, followed by cutting its connection with the lacrimal canaliculae. So we have to cut the connection with the lacrimal canaliculae. Then this lacrimal sac is held with artery forceps and twisted 3 to 4 times to tear it away from the nasolacrimal duct. So after that, curettage of bony nasolacrimal duct. The infections remove the infected parts of membranous nasolacrimal duct with the help of lacrimal curette. Last closure is same as external DCR. So here nothing but we are removing the lacrimal sac. So thank you. This is all about dacryocystitis. Hope you all enjoyed this one. And I had given two links, YouTube links for the surgery demonstration. You can go through that. First go through this one, understand the surgery, then go to the video and thorough it. Thank you. Have a nice day. Bye. See you all in the next video.